Good afternoon, everyone. I would like to thank the Department of CTVS to giving me this opportunity. For the next 15-20 minutes, we will go through the basics of coronary angiogram, coronary anatomy, and Cath studies. So, first Mason Soames did selective coronary angiogram on himself in 1958. So these are the basic views which were used previously were the right oblique views and left oblique views. How to identify these views, and next views is the cranial views and caudal views, that is the skewness. So how to identify these views we'll discuss. Basically there are three coronary arteries. From the left coronary artery it will branch into the left anterior descending and left circumflex. So both the circumflex and the right coronary artery, they travel in the AV groove, and the anterior and posterior descending arteries, they travel in the septum. So this is an RAV view. This is an RAV view which is enforced with the septum. So it will delineate clearly the left anterior descending and the posterior descendings. So next is the LAV view, which in this view the atrioventricular grooves are enphased. So the right coronary artery and the left coronary left circumflex are visualized better in these views. So this is a right coronary injection taken in the LAV view. So how to identify is it LAV, RAV? So we have to focus on the spine. So to the left side in LAV view. Okay. So this is the spine in the right side and the catheter on the left side with RCA showing the proximal, mid and distal RCAs and branching. So to better view this branching pattern, which is the PDA and PLVB, we will go to the cranial views. So how to identify the cranials? So this is an RCA injection taken in the epicranial view. So how to identify is by the domes of the diaphragm shadowing over the heart shadow. So this is the dome of diaphragm over the heart shadow. So in cranial views the dome of diaphragm will be shadowing on the heart. So in this view in RCA we can better delineate the branching pattern. The lower one is the posterior descending artery running along the septum, and then this is the posterior left ventricular branches. So this is the left injection taken in the LAV caudal view. How to identify this view? So the spine is on the right side of the screen and the catheter is on the left side, and this is an epicaudal view. So how to identify? This is the spine here and the catheter is on the spine. So it is AP projection with there is no overshadowing and there is no domes of the diaphragm visible. So it is a caudal view, and the ribs, we can see for the rib structure. These are concave. Ribs are concave here. So in the caudal views the ribs are concave. So this is a left main. This is the left main dividing into LAD, and this is the LCX. This is the LCX. This is the maybe a high OM or ramus intermedius branch. This is the obtuse marginal branch from the LCX. This is the distal LCX running in the left AV groove. So LAV caudal view is better for the LM and proximal LAD and proximal LCX. Basically the LCX will be visualized better in the caudal views. It will make the LCX elongated and the proximal and the distal LCX and the origins of the OMs will be better visualized in the caudal views. After this, we can go to the cranial views. We can see the dome of diaphragm overlying the heart shadow. This is the left main giving rise to the left anterior descending branch. So this is the proximal LAD, mid LAD and distal LAD. How we divide is by the branching pattern. So LAD gives rise to the diagonals and the septals. These are the septals. These are small branches are the septals, and the branching pattern to the right side of the left anterior descending are the diagonals. This one diagonal 1, D2, and these are the small septal branches. So before the origin of the diagonal is the proximal LAD, after the diagonal is the mid LAD and distal LAD part. So better delineating the LAD is by going to the RAO cranial view. In this view, the spine is to the left of the screen, which is not visible here, and catheter is to the right. This is an RAO view cranial. The dome of diaphragm is overlying the shadow, and in cranial views the ribs are convex. Ribs are seen as convex, unless like in caudal views they are concave. These are some tips to identify which is a cranial view, caudal view, LAO and RAO. So this RAO cranial view will make the left anterior descending lengthen so that it can be studied. So the next view is LAO cranial view. This is another angiogram. This is the LAO caudal view. The spine is on the right side and the catheter is on the left side. So this is the short LM. Short LM. In LAO caudal view, the LAD will go like this and the LCX will drop down. This is an apicaudal view, LM. This is the LAD and this is the proximal LCX giving rise to OM1, 2 and 3, and this small branch is the distal LCX. This is an LAO cranial view to better delineate the dominance of the coronary arteries. After studying these, we have to know which artery is dominant. Most of the time, 80% of the cases, right dominance is present, which is the dominance is set by the whichever artery gives rise to the posterior descending, it is the dominant vessel. So in this case, the RCA is giving rise to the PDA, and this is PLVB. So this is, in this case, this is the right dominant, and this is the LAO cranial view with LCX, and this is a non-dominant LCX. So another example of this left dominance is the right coronary artery giving rise to the proximal RCA with this is the SA nodal branch or conal branch, followed by the acute marginal branches and stopping there. This is an LAO cranial view showing that this is the PDA, distal LCX continuing as the PDA. It is better delineated in the LAO cranial view. So after assessing the branching pattern and identifying the coronary arteries, we have to focus on the coronary artery lesion stenosis. So a coronary artery having a 50% diameter to assess the severity of the stenosis, we always have to take the reference diameter of the distal vessel. So in this, the distal reference, when we compare with this to this, the 50% reduction in the diameter is seen, which corresponds to the 75% of the stenosis of the area wise. So if the diameter stenosis is 70%, it corresponds to the 90% area stenosis. And if there is only a thin line compared to the distal reference, that is the 90% stenosis, diameter stenosis compared to the corresponding to the 99% area stenosis. So this is another angiogram just to show the severity of the, just to assess the severity of the lesion. In one view, we have to assess the lesion severity in multiple orthogonal views. This is an RAO cranial view showing the mid LAD part. When we compare to the distal part, the reference vessel diameter is 50%, more than 50% stenosis, corresponding to a 70% area stenosis. We have to confirm it in the another orthogonal view. That is an LAO cranial view. In here, we have to confirm the diameter stenosis in two orthogonal views. So next, coming to the RCA, this is an illustration showing the osteoproximal RCA stenosis. When we compared the mid RCA diameter to the proximal RCA, the diameter is less than half. So how to know is this a good sized vessel, or how to compare is by the catheter size. We usually do angiograms with a 5 French catheter. So 5 French literally transforms to 1.7 mm. So we have to compare the lesion severity and the lesion vessel size with the catheter size. This is a 5 French OptiTorque Tiger catheter. When we compare with this proximal RCA is exactly the size of this catheter, and the distal RCA is somewhat something like 1.75 times the catheter size. So we have stunted this lesion. So this is the result. This is the result, proximal RCA. So after this, we can go for the ventriculograms to better delineate the valvular severity, stenosis, and to delineate the HOCM severity, and for the aortic pressures and LV, EDPs, everything. So this is a RAO view. How we are telling is by the spine is to the left side of the screen and the catheter is to the right side of the screen, and the catheter course is from the femoral artery, descending thoracic aorta, ascending aorta, retrogradely crossing. This is the aortic valve. No. This is the aortic valve, and the pigtail is in the LV. So this is a left ventricular aortogram. This is the left atrium. If there is a mitral regurgitation, the reflex of contrast can be seen entering into the left atrium in this view. So left ventriculogram is taken better in the RAO view, RAO 30. So because it is emphasized with the septum. This is the right ventriculogram, which is usually taken in the epicranial view. It's taken in the epicranial. Cranial is to elongate the right ventricular outflow tract. And how to say which is the right ventricle and which is the left ventricle. So if we observe here, there are fine trabeculations compared to this. There are coarse trabeculations. Right ventricle is a coarsely trabeculated ventricle. So, and the ventriculogram, RV ventriculogram is taken in the epicranial view to elongate the RVOT. This is the the RVOT. There is an infundibulary stenosis with this is the pulmonary artery filling. This is the pulmonary artery, and this is the aorta. There is a VSD in this case. This is an aortic root angio taken by retrogradely putting the pigtail catheter in the root of angio. And if there is an aortic regurgitation, we can see the reflux of the contrast into the left ventricle. And this aortic root angio is taken in the L overview. This is the spine here and the catheter is here. So this is the L overview. If we take the spine in our right hand and if the catheter comes into the left hand, this is an L overview. And if the spine is in the right hand and if our catheter comes to the right hand, this is an R overview. This is an L overview showing, this is usually taken for the aortic regurgitations and usually to demonstrate the coronary anatomies in most of the congenital cases. So coming to the Cath studies, usually these are done to assess the pressures and the oxymetry run, to assess the lesion severity like ASD, VSD, left to right shunting, right to left shunting, and the QPQS calculations and the PVR calculations before the proceeding for the transplantation or other congenital surgeries. So catheter course, we usually use a Swan-Ganz 7 French catheter retrogradely going from the femoral vein, IVC, and this is the RA. The catheter is looped in the RA to ease the entry into the RV, and this is the RV OT and entering into the main pulmonary artery and into the right pulmonary artery. If you can observe here, this is the balloon tipped. We wedge it in the zone 3 or zone 2. We occlude the blood flow distal to the balloon so that there is an end hole which can detect the pressures. This is how we calculate the pulmonary capillary wedge pressure. And if we occlude the blood flow to the segment, the end hole will see the distant pressures, which are the LA pressures. So we routinely cannot cross into the LA. So we take the pulmonary capillary wedge as the surrogate for the LA pressures. After taking the pulmonary capillary wedge pressure, we note the coronary pressure waveforms and we take the samples. And these are the coronary waveforms, pressure waveforms, the ACXY in the right atrium and the pulmonary capillary wedge, which is a surrogate for the left atrium, the ACXY waves, and the RV and PA. How to differentiate between the ventricle and the great arterial pressures. In the ventricle, during the diastole, the pressure rises. So this red arrow shows the rising of the pressure during the diastole. That means we are in the ventricle. In the diastole, if the pressure is decreasing, that means we are in the great artery, either aorta or pulmonary artery. So after entering into the pulmonary artery, we usually tend to take, for the shunting calculation, we usually tend to take oximetry run, which has to be completed within 7 minutes. We take samples, 2 ml samples from the left and right pulmonary artery, main pulmonary artery, right ventricular outflow tract, mid and inflow, right atrium at 3 levels, low, high and mid level, superior vena cava, high level and low level, inferior vena cava, low and high level, and from the left ventricle or from the femoral artery. So after that, calculation of the significance of the shunt is taken by the difference in the oximetry samples from the if we take IVC to right atrium, if the saturations rise of more than 11 in a single sample, this table corresponds to the single sample measurements. If the rise of the saturation is more than 11 at the level of the atrium, it is significant. At the level of ventricle, it is more than 10. At the level of great vessels, it is more than 8. And at any level, it is more. If it is more than 8, it is significant. So if we take an example, the IVC saturation is 73 and SVC is 67. We have to combine it by taking a mixed venous saturation by 3 into 3 SVCs plus 1 IVC by 4. So it approximately comes to 70% saturation. In the mid right atrium, that is 84% saturation. So the average of 70 to 84, the step up is more than 14. The level of atria which is significant is the 11. So we got 14. So it is a significant shunt significant step up in the at the level of the atrium. So most likely by the ASD from the left to right shunting. So at the level of the ventricle, at the level of the great arteries, we can calculate that. And after the calculation of the pressures and the samples, we have to calculate the QP, QS by these equations. We have to know the oxygen consumption. We have to know the pulmonary vein oxygen saturation. We usually arbitrarily take it as 98%, and pulmonary artery we take from the oximetry run. We have to know the systemic artery, that is femoral artery saturations, and mixed venous oxygen saturation. And after that we have to calculate the QPQS to know the significance of the shunt. If the shunt is more than 1.5 times, QP by QS is more than 1.5 times, it is a significant shunt. If it is more than 2, it is a large shunt. So after calculating the shunt, we have to calculate the systemic vascular resistance, total pulmonary resistance, and PVR. PVR is an important aspect in the treatment perspective. For the pH, to classify it as pre-capillary pH, post-capillary pH. So these are some of the normal values of the systemic vascular resistance and pulmonary vascular resistance. Thank you.
Thank you, sir.
And cranial views for mid and distal part of the coronaries and the percent of stenosis. You always should compare with two diametrically opposite views to control the stenosis severity. All these things, you see more angiograms, you will learn better. That is the crux of the issue. Thank you.
Dr. Shailesh, sir.
పడుతుందా పక్కకి